evening, everybody that is here. Thank you so much for setting aside an hour of your Thursday evening to learn a little bit about hip pain in the adolescent and young adult athlete. My name is Dr. Linnea Welton. I am head of the Hip Preservation Service with MultiCare Health System. I'm a dual fellowship trained surgeon in both sports medicine as well as hip preservation. In addition to that, right now I'm currently acting as the South King County Regional Medical Manager for our orthopedic surgery division. And what else? Well, I'm currently the highest volume hip preservationist, hip arthroscopist in Washington State. And it is a great honor that I get to serve not only my local community on the east and west side of the mountains, but I also get to help people that come out to see us from Alaska, Montana, Idaho, and Oregon. So let's get down to what the topic is that we're going to be talking about tonight. I guess one final thing is when I think about a hip preservation service, it's really not just about me and the patient. All right. I have many players that we work with on a regular basis, but the two key integral members of my team are Lisa Kenny, who is my athletic trainer for our patients. She is basically acts as a patient liaison, and she helps take care of patients before I see them, after I see them, virtually and in person, and helps make sure that we try and provide as seamless, high quality care as possible. And then Krista Guile is my PA, and she helps me in the operating room. And she's also really important in helping me see patients after surgery to make sure that we get them back on the road to sport and recovery as fast as possible. So the objectives for tonight's topic are just to introduce it, to talk about some of the historical sort of nuances of how patients present with different injuries. We'll talk a little bit about the examination that myself or another provider, whether it's an athletic trainer, a physical therapist, or a pediatrician might do to kind of help determine, some of the key factors that are causing that patient, that athlete's pain. Then we're going to go through some common diagnoses that we see and how we treat those. This certainly is not comprehensive, but this is some of the leading kind of players that we think about when a young athlete develops hip pain, and then just some closing thoughts. So hip injury in the adolescent athlete is somewhat common. It makes up about 6% of sports injuries. And they're most commonly due to soft tissue, which means muscle, tendon, ligament, and then also apophyseal injuries. And the apophysis is basically a bony growth center that is where a tendon attaches a muscle to the bone. And so as kids and adolescents, as they grow, where the tendon is pulling on the bone to make a joint move is at the apophysis. And the apophysis has a relative area of weakness because the growth center of that sort of bony protuberance actually is made of cartilage. And so in young patients, before that cartilage has turned completely to bone, that's actually a weaker area than the tendon is for like adults. Most of the time when patients, athletes in their 30s and 40s, when we injure ourselves and it's a soft tissue injury, it's going to be the tendon tearing from the bone. For younger adults, it's going to be that little growth plate pulling off. Anywho, so oftentimes the initial injury is thought to be a hip flexor strain. And when we think about recovery processes for low-grade soft tissue kind of bruises or strains, usually loss of play is only about 1 week. When we start to get deeper into the actual hip joint, the results of when we look at how long patients are out of play or out of sport, it can be up to up to 8 months or longer. And part of that just entails making sure that trying non-surgical things, making sure the diagnosis is correct, and then the recovery process for those individuals that actually require surgery. And then I think that this is really interesting, that there are unique risk factors that put adolescents and young adults at risk for certain types of injuries. And one of the reasons is that we see an overall reduction in coordination in young patients, and that's because there's this imbalance of where the bones and the limbs are getting longer during their growth spurts, but the mass, the muscles and the tendons are not catching up or not able to stay kind of on top of that growth. And so there just isn't as much muscular control of those growing bones. Also, because of that rapid growth, there's relative inflexibility of that musculature. So the tendons and the muscles tend to be more tight because, again, the growth of the bone is overtaking the growth of the muscle and tendons. And then finally, like we talked about, is that open sort of growth plate of the apophysis, and where the tendons attach to the bones are at weaker than the tendon is. So in terms of what we're thinking about as providers when we are initially meeting a patient, an athlete, and trying to figure out what it is that's causing them pain, first thing, some of the first things we think about are the onset. Was this something that kind of came on over time? Or was there like an acute sort of rapid, like it happened exactly when I did this and it had never happened before? Also, how did the injury occur? Was it, during competition? Was it during a jumping, rapid acceleration or deceleration? Where's the location of the pain? Is it located in just one area, or is it more sort of diffuse, like all around the hip, or is it in the buttock or up more towards the back? And then certainly if patients say that, man, I heard and I felt a pop, that always makes me think about that apophyseal injury, about that growth plate kind of pulling away from the bone. Other historical thing sort of in the history taking when we're trying to learn more about how the injury started or the pain started is what things also occur with the pain, what reduces the patient's symptoms, what has been done so far in terms of treatment, therapy, anti-inflammatories, periods of rest away from sport, and is this something that they've experienced before? Is this a recurrent issue? Then after that, we generally move to an exam, all right? And I think of the hip joint in a very layered approach. And the reason for that is because the hip is the one joint in the body that has the broadest range of possible diagnoses. Certainly, we have the muscles and tendons, the bone and growth centers, and the cartilage and ligaments. But then also encapsulated within this very sort of broad structure are the nerves, the arteries and veins, and then it's very close to the spine. So sometimes there can be spine that mimics hip pain or hip pain that mimics spine pain. Then right adjacent to the inner wall of the hip joint, you get into the pelvic cavity. So it can also be, are there internal organs for females? Is it associated with their menstrual cycle? Or are there, does the pain like radiate to a young male athlete's testicle? All these things can help point us in the direction of, is it truly coming from the joint or is it coming from somewhere else? And then, of course, finally, there's sometimes systemic conditions like juvenile rheumatoid arthritis or other things where if we see it on both sides, we start to, want to make sure that there isn't something that's involving kind of beyond just the joint. On the exam, especially once a patient has come to my clinic because they have usually failed other non-surgical modalities, I really do a very thorough exam. So I'm looking at how they walk. Are they lopsided? Do they toe in? Do they toe out? Do they have any hypermobility of their joints? What is their core, their glute strength look like? Um, on the table, when I have a patient lying down, either on their back or their front, I often start with kind of inspecting to make sure that there isn't any bruising or swelling. And then I touch, which is called palpation, some of the most common sort of apophyseal injury areas. So those growth centers, which are where usually the hip flexors attach at what's called the ASIS, the AIIS. If they have posterior buttock pain, then I'm thinking, sometimes I'll think about a hamstring injury. So I'll palpate at the ischial tuberosity. And then you also have where your glutes and your hip flexors attach to down lower on the hip at the top part of the femur. I check a patient's motion because sometimes asymmetry in motion or abnormal ranges of motion can help give us an indicator of if there's a bony hip shape or socket or femur shape that could be leading to why a patient has pain. And I do this both when they're lying down on their backs and also when they're on their bellies. Then we also do a lot of work testing the different hip muscles because whether or not the problem is coming from the muscle itself, it is also not uncommon for us to see that even if a patient's having most of their pain coming from the joint where the cartilage is, we will oftentimes see that there's compensatory pain coming from the hip flexors or the glutes or the adductors because the body is trying to compensate and reduce pain in the joint, but that can cause some mechanical alterations, which can cause irritation in the muscle groups that support the joints as well. Then there are lots of tests that we do to try and determine whether or not a patient's having pain that is coming from in the joint versus around it. These are some of the most important sort of maneuvers that we do. And then I always try to grade a patient's pain about whether or not pain that I cause on the exam is actually the pain that they're dealing with, or if it's just pain that I've caused them that's not actually pain that they normally experience. Because I want to make sure that we're really hitting the nail on the head and getting to what their pain and symptoms are. The next thing that any patient that comes to see me, we review are x-rays, and then if they come with an MRI. The x-rays, I have them come in and I get specific images that are corrected for me to be able to make about 20 different measurements on a front view of the pelvis like you see here, because I really want to make sure that I'm leaving no stone unturned and understanding a patient's hip shape and pelvic sort of structure so that I'm not leaving anything behind. And so we need to often get what's called corrected views to make sure that I'm trying to be as objective as possible. And some of the other views that we get are with the knees sort of butterfly to the outside. They get us what's called a done view, which allows me to look for something that's called hip impingement or a cam type hip impingement. And then we also get what's called a false profile, which is kind of a side view of the hip. And that's really helpful for me to look at, one, the joint to see if there's over or under coverage, and then also to look for some of those apophyseal injuries that may be coming off of the hip flexors. MRIs and MR arthrograms, I think, are also really helpful. One, they tell us about labral tears. Two, they can show us about some mild apophyseal injuries that may not show up on an x-ray. And then they can show us more rare things like athletic pubalgia, which is called a sports hernia. And then the big bad thing that we always don't want to miss is a stress fracture, especially in our long distance athletes. Before I do a surgery on anyone when it's involving the joint, so the ball and the socket, I always get a CT scan, which allows me to generate a 3D model of the joint so they can plan a surgery as precisely as possible and make sure, again, that I'm not missing sort of any bigger or broader picture abnormalities in the joint. Oh, and here's just a little view of kind of a video of how I'm able to manipulate that CT scan that's generated from a patient's actual image to sort of determine what I need to be considering. So what are all the certain things that we should be looking about in terms of a diagnosis? How do we make the diagnosis, and then how do we treat it? So one of the most common things that I see is something that's called femoroacetabular impingement, or FAI for short, or also very commonly known as just hip impingement. And that's basically where, if you think of, I want to ask a question. In addition to sharing my screen, can the audience at all see me, Jensen? Or is it
Yes.
just, they can?
You're at
Okay,
the
great.
top.
Okay, great. So this is oftentimes how I think about hip impingement. And so I like to use my hands when I describe this concept. So let's say that this hand is the hip socket, okay, which is a deep cup. And my fist is the femoral head and my wrist is the femoral neck. In a normally shaped hip socket, you can go through a really large range of motion before the two bones can theoretically conflict or impinge. Now, in a patient who has either too much bone on the socket, which is called a pincer type hip shape, or too much bone on the femoral head and neck, um, if there's too much bone in either or both of these, the range of motion is lower, all right? There's less of an arc before the two bones can conflict or impinge with one another. And what gets pinched is the labrum, which is the cartilage gasket that goes around the hip socket. We're going to go through this over the next few slides. So here's just a depiction of what a cam type hip shape looks like. A pincer type hip shape, again, is usually where there's a little or a lot too much bone, either on the side, the front, or globally throughout the socket. Okay. And like I said, I see FAI or hip impingement commonly, but it is also common to have this hip shape, but actually not have any symptoms, which is very interesting. So there have been studies done looking at how much of the non-painful hip population has a cam or pincer type hip shape on a regular radiograph, or x-ray, I should say. And so up to 67% of a non-painful population can actually have some amount of a pincer deformity on an x-ray. And this hip shape that is not associated necessarily with pain is actually much more common in the athletic population. You will see this about 3 times more commonly to have a pincer or cam type hip shape in an athlete than you will in a non-athlete. And we think that some of that is because part of the reason why why impingement hip shape develops is due to higher activity, higher hip flexion sports. But what are the symptoms of hip impingement? Well, oftentimes there's pain with sitting, there's pain with squatting or high flexion activities. Most of the time, that pain is in the front of the joint. Sometimes it'll be even towards like the groin. But patients can also present with pain that's deep in the side, or what they will say is kind of C-shaped, like wraps around the whole hip. And then some patients will even describe that their pain is in the deep sort of buttock region. So definitely it's not very specific. Some patients will say that they get some kind of mechanical symptoms, some catching or clicking. And then oftentimes the pain can progress to where really everything aggravates it. Some of the examination pearls that really raise my index of suspicion are if, when I try and provoke an impingement type scenario in their socket, if that causes pain, if they have reduced motion, especially when I try to rotate their hip internally. And then if they have other things that that sort of show me that they're having pain that's not necessarily coming so much from the muscles, but mostly from the hip. Then again, we talk about the x-rays, an MRI to look for a labral tear. And then I also commonly use a diagnostic injection. And a diagnostic injection is usually done with an ultrasound machine that I have one of my non-surgical sports medicine colleagues do. And that can help confirm when we numb the hip joint. So when we numb up that labrum and that cartilage, if a patient's, an athlete's pain goes away for any portion of a couple of hours after the injection, it helps prove that yes, they have pain that's coming from the joint. And it's especially, I think, critical to consider doing those injections based upon the knowledge that there are so many patients and athletes out there with a hip impingement type hip shape and even a labral tear. But we know that not all of those people are painful. So we want to make sure that we're really, again, hitting the nail on the head in terms of coming up with the right treatment. And yeah, so here's a slide that I like to share about how common labral tears are too. So there, again, have been several studies where MRIs were done in the non-painful population, and 40 to 80% of those populations had a labral tear on an MRI. So this is a great demonstration that, not all labral tears are painful, which is great in the sense that it also means that not all labral tears have to have surgery. And that's why the mainstay of treatment initially for a patient with hip impingement with a labral tear is to try non-surgical things like physical therapy. Because if somebody who has a labral tear on a random MRI doesn't have hip pain, and they haven't had surgery on it, then that means we have an opportunity to make a painful labral tear non-painful by trying to alter their gait, their mechanics, and sort of do other things to try and tamp down that inflammatory process that's causing pain. So there are many studies that have been done looking at, should we be treating patients with hip impingement with physical therapy, or if they should be treated with a hip arthroscopy or a surgery to fix the impingement type hip shape and the ensuing labral tear. And there are definitely a cohort of patients that can do very well with physical therapy and not have to have surgery. However, I will say that a lot of these studies do show that there is a pretty significant portion of patients that cross over, i.e. patients that try physical therapy but end up not getting the pain relief they need, so they do ultimately end up having a hip surgery. But it's that portion of the population that doesn't need surgery. We really want to make sure that we offer them a chance to prove whether or not they can recover without a surgery or do need a surgery. And the caveat to this is that I will emphasize physical therapy less if somebody comes to me, if a young patient comes to me and they have significant deformity. They don't have just a mild impingement type hip shape, but it is significant. And certainly if there is any indication of early hip arthritis, even in 18, 20, 22-year-olds, then I will really emphasize that we probably shouldn't try physical therapy for too long. But fortunately, that's not very common. So again, as I've talked about, the mainstay of initial treatment is physical therapy. And we really want to work on sort of range of motion, on mobility, on how to utilize the muscles around the hip that are so strong to better protect the joint and alter the mechanics so we can get a patient back to sport but without having that pain. For in-season athletes, again, we try to reduce the activities that cause pain if they are a high-level athlete to try and get them through the rest of their season. And other things that we do to supplement this with are anti-inflammatories like Aleve or ibuprofen. And then again, to try an injection sometimes, not only for diagnostic purposes, but in those very high-level young athletes that really need to get through a season, like they, are waiting, they're trying to get a college scholarship, or they're at the collegiate level and it's important for them to play. We will occasionally do a single corticosteroid injection or a biologic injection like PRP. Now, for those patients that have tried those things, but they still aren't able to get back to play or get back to their active lifestyle, the most common surgery to treat this condition is something that's called hip arthroscopy. And this is a minimally invasive surgery where I usually make 2 to 3 incisions that are about the diameter of my finger is all to get access into the joint. And that allows me to put a camera in so that I can visualize the cartilage, the labrum, the capsule around it, And then it allows me to repair the labrum, so to take away the pain, okay? And then the other really important thing is for me to correct the hip shape that caused this to occur. This video here is just a demonstration of how we do, one of the ways that we do a labral repair. And so on the right, you see that there is the cartilage of the femoral head, which is kind of that circular structure. And then to the left, deep, sort of in the shady area, that's the cartilage of the hip socket. And then where the sutures are being passed, that is the labral tissue, which is that gasket that goes around the hip joint. And so, like I said, we have to correct the deformity or the hip shape that caused the patient's labrum to tear. And so the purpose of that is, one, to make sure the labrum doesn't tear again. And two, especially with cases of more severe deformity, we know that they are a leading cause of the development of early hip arthritis. So we want to try and prevent arthritis from developing in an early active population. And so here's just a demonstration of how I use a CT scan that's in the center image to kind of understand in 3D where their hip impingement deformity is. And then I equate that to intraoperative. So during like real-time surgery, I'll take x-rays to template out exactly where I need to track and correct that deformity. And then this is just a stepwise progression that I use to create a more normally contoured femoral head and neck junction. And then these are just some of the postoperative radiographs of a CAM and a pincer lesion. And now, not all labral tears are caused by hip impingement. Another big player in young adolescents and early adults to have a labral tear or hip pain is from what's called hip instability or hip dysplasia. And that's when, instead of the socket having too much bone, the socket actually has too little bone. And so that socket is shallow. And so the way that causes a labral tear is, one, there's some shearing forces. And so those shearing forces, because of that micro motion that a patient usually doesn't feel, that causes tearing basically kind of from the inside of the joint towards the outside, all right? And oftentimes we see this in patients that have joint hypermobility, so dancers, gymnasts, aerialists, these sorts of things. There's usually not an acute episode, but it sort of just comes on out of nowhere that they start having pain. Sometimes patients will express that they started to have pain when they were doing upright things, but it will progress to more seated positions. Rarely, like I said, do they have sort of a shifting sensation. And again, the location of the pain is really non-specific. Most commonly, it's in the front and the groin, but it can be on the side, it can be in the buttocks as well. The diagnosis for instability-related pain usually includes a more thorough analysis, if I'm concerned about this, of more instability testing to see if that's a component of their pain or of their symptomatology. And this is just some sort of examination maneuvers that I add into the exam to make sure that I'm not missing this. Then for hip instability, there's again a lot of measurements that we do, both on the x-rays. There are also signs that we look for that are unique to patients with hip instability, such as the labrum being too thick. And then the CT can further demonstrate how unstable a patient's joint is based upon things like how their hip is rotated in space and how much what we call uncoverage, how little of that femoral head is covered by the socket. And so again, the treatment for initially for hip instability, especially in this young population, is all about good physical therapy. And the reason being is that especially patients that have a shallow joint, they tend to be what we call hypermobile or double jointed. And so their ligaments don't protect their joint usually in multiple areas as much as other people. And so we really have to focus on strengthening the muscles around the hip to better protect the joint. And I will say that patients that are young in their adolescence, they are much more plastic and pliable in the sense that their ability to sort of recalibrate their joint mechanics and their sports mechanics is much better than patients who are in their 30s and 40s. We tend to be more in adulthood, more concrete. We have been living our lives for 30, 40 years doing things one way. And so it's very hard to retrain ourselves to do it another way. So that's why physical therapy, again, is also really important. And then similar to hip impingement, we try anti-inflammatories, and we will sometimes do either a diagnostic or rarely an in-season steroid injection. So the treatment for hip instability is really dependent upon where the instability is and how unstable it is. Okay, so there is hip dysplasia that's frank. We call it like frankly dysplastic, but there's also a borderline, so kind of a gray area where it's a little bit showing some signs of instability, but not frankly dysplastic. And similarly, hip instability or hip dysplasia can oftentimes be seen with concurrent hip impingement, like a cam type hip shape at the same time. So we have to really think about the patient's entire clinical picture to determine, is this a patient, an athlete that we can just do a minimally invasive surgery on, like a hip arthroscopy, or are they someone that we have to do both a hip arthroscopy and then in a staged fashion to do what's called a periacetabular osteotomy, which is when we cut the socket away from the bone, or excuse me, the socket away from the pelvis so that we can reorient it and then fix that bone cuts with several screws to allow the bone to heal in a newly oriented fashion so that the patient's socket is no longer unstable or shallow. Here's just some kind of pre and post x-rays. And then there are many different techniques of how we do this. And so the incisions can range in size, and some of them, can even be hidden by a bikini line. Moving on, okay? That again is what I see and do most of, but I also want to touch on some of these other things. So apophyseal avulsion injuries that are coming from the front of the joint. Again, these are usually due to sort of increased stress across either your rectus femoris or your sartorius muscle or your iliopsoas muscle. And they tend to occur, the ones that are up higher on the crust tend to occur in older adolescents, whereas the anterior inferior iliac spine, which is closer to the hip socket, tends to occur in younger patients. We see these more in males than females, and I think it has to do one with sometimes the velocity of motion, and two, sort of that bigger growth spurt that males see. We will often, like I said, hear that the patient heard a pop, and it's usually in a high flexion scenario. So they were running, they were kicking, they were jumping, and they had this excruciating pain. And because of that pain, they'll also usually have some weakness when we test for strength testing of those hip flexor muscle groups. X-rays can be very helpful because they can show us if that little growth center has pulled off and by how much it has pulled off. Most apophyseal avulsion injuries, that the little growth center pulls up very little, like usually less than 2 centimeters. And so patients, athletes that have these apophyseal injuries where the growth center has pulled off less than 2 centimeters, we treat these non-surgically. And patients, we have to shut the patient down for several weeks to basically calm that inflammatory pain process down and to allow for some early healing. They have to use crutches for a period of time. Then we get them into physical therapy. And most patients are able to return to sport within 3 to 4 months. When we see a sort of more rare instance where a bone that bony center has popped off and it's like 4 centimeters retracted, I just saw an athlete with this, then we offer a surgical intervention to basically reattach that bone that growth center back to where it came from. And the recovery and rehab process is very much the same once we have corrected and fixed that injury. The one thing I will say is for those patients where there is what we call an AIIS avulsion, which is where the rectus femoris hip flexor attaches to, sometimes if that bone is pulled off a fair amount, that puts them at risk for developing what's called subspine impingement, which is a type of hip impingement where the femoral head and neck actually impinges up against that bony protuberance that has healed kind of off the bone. Again, not very common, but it's always something that I kind of, have a high index of suspicion for or talk to the family about to be aware of moving forward. Now, the other type of apophyseal injuries are ones that are sort of in the buttock. And the one that's in the butt that we will sometimes see is what's called an ischial tuberosity avulsion. And that is where your hamstrings attack or originate from. And so we commonly, if you see an apophyseal injury, you'll oftentimes see swelling and bruising that travels down the thigh. That pop will be heard, but it will be buttock or sort of deep thigh pain in the back. And then these are just some exam pictures of kind of some of the maneuvers that I test if we aren't sure if it's an apophyseal injury or not from the hamstring. Again, most of the time we treat these without surgery. They heal well, especially in this young population. However, for patients where we see a larger amount of retraction, then we will offer surgery to fix the bone back down to its origin or to where it came from, or we'll do it with some sort of sports medicine type of screws if it's just a very small little slip of bone. And again, recovery process is similar, though usually if we have to do surgery, the recovery process on this one is a little bit longer, and that's just because there are so many muscles that make up the hamstring group, and there's so much force applied to that area that we really need to kind of shut patients down, those athletes down, while that bone is healing back together. So next thing I want to talk about is what's called the snapping hip. Okay, so different diagnoses. And this oftentimes may not even be painful. It's just a really weird noise. The most common type is what's called the external or outer snapping hip. And that's where the IT band, which is the band of tissue that comes off of the iliac crest and then travels down the outside of the leg and attaches down at the bottom of the knee. And usually patients will be able to demonstrate this popping or snapping. And it's either coming from the IT band or the gluteus maximus. For internal or snapping that's felt in the front of the hip or in the groin, that can be coming from one of the hip flexors called the iliopsoas as it rolls over either the femoral head or the capsule or from the upper portion of the pelvis. So often I have had patients describe this external snapping hip as a hip dislocating because it can feel like such a profound sort of snap of that IT band rolling over what's called the greater trochanter. And again, oftentimes patients can sort of show this to me. For the internal snapping hip, that usually is more of a sort of getting stuck or locking sensation. And it can mimic, or sometimes a labral tear can also kind of have a similar symptomatology. I will say that the examination is different for both different types of snapping hip, but there are certain maneuvers we can do to try and elicit that. And again, if I elicit that snapping and that is the pain or the snapping that they're talking about, then I know that I'm hitting the nail on the head. Most of the time, if we get x-rays, a CT scan, or an MRI, the soft tissues will look completely normal. So they are imaging in this particular diagnosis is not terribly helpful. Sometimes you can, if you have a really good ultrasonographer, you can actually see on ultrasonography the IT band snapping over that greater trochanter, but we usually don't need to do an ultrasound to make this diagnosis. In terms of the treatment, if a patient has a non-painful snapping hip, i.e. it's just a weird, it just feels weird or it looks weird, it's nothing, we don't worry about it. There's nothing that has to be done for this. When we think about how we treat this though, if it is painful, again, physical therapy, physical therapy, physical therapy. This we try and really exhaust, again, strength, mechanics, and mobility to try and correct this. And it usually does improve, but it can take several months. If a patient's having a lot of pain, there's a lot of inflammation, doing a steroid injection around the tendon, around the snapping area, can be very helpful. If one is effective, but it comes back, then we will sometimes consider doing a second injection. There are, and this is again pretty rare that we ever have to do something surgical. The surgical solution for this is to either lengthen or basically partially cut that tendon. And especially in young athletes, I really am hesitant to do that, because while most patients don't feel weakness, there is that potential risk that because we have cut or lengthened part of the tendon that's snapping, that they can have altered mechanics and they can feel some weakness. So if they're a sprinter or a hurdler or any sort of cutting, pivoting, twisting athlete, I really want to try and make sure that we don't do surgery unless it's unless there's no other option to get them better. Another diagnosis to touch on is what's called athletic pubalgia. There are 3 types of athletic pubalgia, and that's osteitis pubis, adductor tendon injuries, and then a sports hernia. These are usually the result of overuse or stress injuries. However, there are situations where it can be sort of rapid onset. I feel like I see the rapid onset injuries more frequently in my jiu-jitsu athletes. So osteitis pubis is basically a stress injury right where the pubic symphysis at the bone, all right? And it's because there is a fulcrum of force generation at the anterior pelvis, because that is where your rectus abdominis, so your abdominal muscles attach, as well as where the adductor muscles attach. And so the two are kind of pulling in alternate forces and alternate trajectories. And so that can cause overuse or stress. Patients will oftentimes have pain at the pubic symphysis, so right in the middle of their pelvis. And then it can be painful both there and then kind of off to the sides. Sometimes FAI hip impingement can aggravate this, or can actually be a cause of this. And we'll talk about that a bit later as well. Again, mainstay of treatment is physical therapy and a period of rest. We have to take away the inciting activity, the inciting sport that is causing pain. And that is always, I feel like, no matter what the injury in my young athletes, the hardest thing to do is to say, we have to shut you down. We have to take you out of sport more than just a week. It could be, 4 to 6 weeks, and get you into physical therapy. Anti-inflammatories, injections. Baker, I need you. This is my son, Baker. I'm in the middle of giving a big presentation. I need you to go to Papa, okay? And then can you shut the door? Sorry about that. I love you. Okay. So anti-inflammatories, the injections can also be done. Anti-inflammatory or biologic injections like platelet-rich plasma can be very effective. And then again, rare do we ever have to do a surgery, which can be kind of extensive, to try and fix the osteitis pubis. Other common things are adductor strains. we will usually see a strain over a tear, and the adductor longus is the most common muscle of this adductor group. And I always try to think about adductors in terms of what the function of what an adductor does is that it adds the two legs together. So you're bringing the muscles that bring your leg, the muscles that allow you to cross your legs. Those are the muscles that attach here at the pubic symphysis. There will usually be pain when I try and test a patient to bring their hip together. Also, if I try and stretch their hip out to the side, their leg out to the side, that can cause pain. And then it's a sensitive exam because the adductor is kind of attached right up into the groin, but they will usually an athlete will have pain right up along that tendon insertion. Again, x-rays usually will be normal. An MRI may show a strain or even a avulsion of that tendon. And unless there's, a tendon is torn more than 2 centimeters, we far and away can usually get patients back with a period of rest, physical therapy, anti-inflammatories, and sometimes biologic injections. The same thing goes for what's called a sports hernia. And that's where instead of the tendon of the adductor just attaching or the bone of the pubic symphysis getting injured, it's where kind of the core muscle where the rectus abdominis and the adductor attach together, that area becomes torn away from the pubic symphysis. Again, we see this a lot in hockey, soccer, football, jiu-jitsu players. And in this particular instance, we see this very commonly with patients who have FAI. So the first thing I will do if I have a patient that I'm worried about a sports hernia is I will say, I wonder if some of their pain is actually coming from their joint. And so I will test for joint related pain, and I will get a diagnostic injection into the joint. Because if their pain is improved, which it oftentimes is when I do an injection for hip impingement, then I will actually operate on the hip and not the sports hernia. And the reason being is because we think that when a patient has really bad hip impingement, as their femoral head is abutting and pushing up into the socket, that force causes or translates into added stress onto the pubic symphysis and that whole sort of core muscle adductor complex. And so if we take away the hip impingement, if we correct it so there's no longer that additional force that's pushing into the pubic symphysis, then we take away the problem of the sports hernia. Again, the sort of history in terms of what causes pain is very similar to osteitis pubis and to an adductor injury. There will be pain, however, oftentimes with sitting up because the rectus abdominis, the abdominal muscles are involved. And then, like I said, I always test or assess for hip impingement, and then I will do diagnostic injections either at the pubic symphysis if I don't think that there is any FAI involved, or at the hip if I think hip impingement could be playing a role in this. As with the pattern for everything tonight, we always try physical therapy first. And in this particular diagnosis, again, usually non-surgical management with anti-inflammatories, sometimes biologic injections and physical therapy correct the problem. And then if we do need to do a surgical repair, there are a few surgeons around the country that take care of these particular injuries. So what do we do about in-season athletes? Like, we're not taking everybody out of sport. So sometimes oftentimes we can keep patients in play if it's really important. But the thing that we never want to miss, and we never want to have a patient or an athlete push through, is something that's called a femoral neck stress fracture. And that is when basically, because of submaximal loading that's applied to the neck of the femur, causes overabsorption of the bone that exceeds basically the metabolic repair properties that the athlete has. We commonly see this in what's called the female triad, of where they have, females take in too few calories. And when we see that, we tend to see these injuries. They also tend to have menstrual dysfunction and what we call low bone mineral density. We now appreciate that this can absolutely occur in males as well. And so the concept of what's called REDS, which is relative energy deficiency in sports, is sort of the newer term that we use for the sort of the constellation of problems that we see in athletes who develop these stress fractures. We often see this in endurance athletes, but also in basketball players, gymnasts, ballet dancers. Again, it tends to occur more commonly in females, but we absolutely can see it in our male athletes too. Some of the biggest risk factors for it are a rapid increase in activity level, whether it's exercise volume that goes up, exercise intensity goes up, or athletes are trying or doing a new type of sport. Certainly shoe wear, poor baseline, sort of strength and mechanics play into it, and then the surface of play as well. When we see patients that have had multiple stress fractures, not necessarily just at the hip, but in the shins, or the ankles, etc., then we start to say, is there an underlying sort of systemic problem that's more endocrine related, hormonal related? And so then we'll start ordering or referring for more aggressive lab testing. History of a stress fracture usually means that they have a gradual onset of groin pain. Sometimes that pain actually will be in the thigh or in the buttock. That pain will occur as the exercise increases. Usually a patient will have pain only when they're upright. So if they sit down, if they rest, then the pain will go away. However, as this problem progresses or gets worse, then they will also say that they have pain all the time and at night too. The examination, again, is not terribly specific, i.e., it can mimic a lot of things, but they'll have pain with extremes of motion. When I try to aggravate the joint, they'll have pain. And they can even have tenderness in the soft tissues, even though the problem's coming from the bone. Diagnoses of a femoral neck stress fracture is based upon imaging. An x-ray oftentimes in 2/3 of situations will not show any problem. And so that's why, the point of care providers, athletic trainers, et cetera, pediatricians, non-surgical sports medicine providers have to have a very high index of suspicion for this, because an MRI is oftentimes needed in order to make this diagnosis. When a diagnosis of a femoral neck stress fracture is made, then we usually get some standard lab work to make sure that we're not missing a more sort of global cause beyond just overtraining. And then we also want to look at dietary habits, training habits, and a patient's mechanics as we're going through the recovery process. Many of these can be treated non-surgically. If the stress fracture is on the underside, basically of the femur, and it takes that stress line goes less than halfway to the other side, to the upper side of the neck of the femur, then we can usually treat these non-surgically. And again, it's a period of real limited activity with crutches, followed by repeat examinations and x-rays, and then beginning physical therapy. The recovery process can take anywhere, or return to play, I should say, occurs anywhere between 3 to 7 months. And then in patients where the fracture extends beyond sort of that halfway mark or comes from the top down, then we have to do a surgical fixation to stabilize that fracture. Again, this is less common that we have to operate on these, but again, we always want to make sure we're getting the diagnosis right. So, some concluding remarks, all right? Hip pain and injury among adolescent and young adult athletes is common. It's really important that the providers that you seek out are doing a good examination and that they are understanding exactly the causes for it. Most injuries are related to soft tissues, so muscle, tendon, ligaments, and don't require surgical intervention, thank goodness. Rehab and recovery for these injuries oftentimes is longer than athletes and their parents want. And that's really hard because I feel like, young athletes, they're part of their identity, or much of their identity can be caught up in their athletic pursuits, and trying to have to take that away, even for a period of 2 to 4 or more weeks, can be really hard. So sometimes we have to partner with a sports psychologist. But in any event, know that if you or your adolescent has these injuries, we're not trying to punish them by shutting them down. It's just really important part of the recovery process. For in-season athletes, we can sometimes get them through a season before surgery if they've sort of failed everything. We always need to be aware of the stress, be aware of a stress fracture. And then finally, if your team or school has access to athletic trainers, use them as a source to begin assessment and early management. If after a couple of weeks, we're not seeing progress, or shutting them down isn't helping, then, absolutely don't be afraid to seek out your pediatrician or a sports medicine provider to get imaging and to get sort of a more thorough examination of what could be going on. So with that, I will leave you some sort of resources if you have further interest in learning about my practice. My website, Linnea Welton MD, is also, I try and put a lot of information on there that's educational. So use that as a source for education. And then finally, I just want to say thank you to Jensen and IRG for letting me do another webinar. I always love the opportunity to, teach the community about something I'm so passionate about, and hopefully provide a little bit knowledge that can be useful for everybody. So with that, I will say I'm done. And if there are any questions, I know it's already 7 o'clock. I'm happy to answer them. I'm going to stop sharing my screen. Are there any questions? Let's see here. It looks like there's a little chat. When screws are installed, are they ever removed later? When are hip replacements required? So great question. So most of the time, the screws that we use today are biocomposite. So oftentimes they're not even, they may not even be metal. And because they're so deeply seated up into the bone, you won't feel them. And so most of the time we don't remove screws. The only time I would say, and that's for like tendon injuries or apophyseal injuries, the only time I will say that we do remove a screw is for my young patients that get PAOs for hip dysplasia. Usually it's in young women who are thin, and so the head of the screw you can usually feel it, and it may be painful if they're wearing a belt. And so we'll remove those in a very simple procedure about a year after, once the bone is really healed. When are hip replacements required? When a patient develops hip arthritis. And even if a patient has hip arthritis, we usually want them to try non-surgical things like injections, anti-inflammatories, activity modification, physical therapy, before we say, we probably should have a hip replacement. And the hip replacement is always an elective procedure, but we generally try to have patients, if they do have arthritis, try non-surgical things first. And we think that if we can get a patient, closer to 50 years old, a hip replacement will likely last that patient their lifetime.